Hello, welcome back. Hopefully everybody enjoyed their break. Well, by the time I recorded this was after my break. But anyway, let's jump straight into it. This is going to be Anatomy 2. The lecture is going to be about the nasal cavity and the larynx. So, the functions of the nasal cavity in the respiratory system in general is twofold. Gas exchange is the main function, and sound production is the secondary function. It's important for us as humans because this is our way to communicate. Some people consider it a secondary function. I personally consider it one of the more important functions that the body has. But beyond that, it also plays a role in regulating thoracic and abdominal pressure. You do that by closing the epiglottis in order to cough or to lift heavy things. So, one of the more common side effects of a laryngectomy, which is the surgical removal of the larynx, is there's going to be a weakness in the arms because there isn't a way for the epiglottis to close and let the pressure build up in order to lift something heavy. I don't know if you noticed, but sometimes when you lift something very heavy, you take a deep breath. The deep breath is there to expand the lungs, and then you don't exhale while you're lifting said object. You hold your breath for a second in order to use that pressure to overcome the it's more of like a muscle summation kind of hurdle, but to overcome that hurdle. Anyway, the respiratory function, the respiratory tracts is divided into the conducting and the respiratory division. And the pharynx, while technically a part of the conducting division, it's really part of the digestive tract. Okay, so let's go through the external nose. There are the frontal bone, as you can see here, and then that's connected to the nasal bone, and then the nose is also connected, or it also articulates with the frontal process of the maxilla. Here are the lateral processes of the septal nasal cartilage. This is going to be the lateral. This is the this is the accessory nasal cartilage. This is the minor alar, while this is going to the major alar. The minor is so hard to see, as you can see here, because it's embedded in this fibrofatty tissue, which makes up the nares. The alar septum and the nasal septum are going to be made of hyaline cartilage. And inside of the nose, there's going to be the nasal septal cartilage right there, and that extends like up and then articulates inside with the ethmoid and the frontal. Like it goes all the way inside of the nasal cavity. The external nose is supplied by the ophthalmic and maxillary arteries, and the skin of the alar and the lower septum of the nose is going to be supplied by the facial artery. And the innervation is the infratrochlear, the anterior ethmoid, and infraorbital nerves. All of those are components of the trigeminal nerve, so you can see here. So the maxillary part of the maxillary division right here is going to be a motor neuron. So this is what allows you to kind of twitch your nose from side to side. The ocular, or the top division, allows you to scrunch your nose. And trigeminal neuralgia, which is going to be a pain from the trigeminal nerve right here in the plexus. It's going to kind of radiate down the jaw to the nose, around the eyes, and like up here to the forehead. Okay, so the nasal cavity proper it starts behind the vestibule, which is right here, and it extends all the way to the cone, and the floor is going to be the palatine process of the maxillary or maxilla and the horizontal plate of the palatine. The roof is going to be part of the frontal bone, the sphenoid bone, and then the cribriform plate, which is embedded in the sphenoid. And the meatuses are going to be these, like, foldings. And the superior meatus is where the posterior ethmoid sinus drains into. And the middle meatus is where most of the sinuses drain into. So the frontal sinus will also drain into it via the frontal nasal duct, along with all the anterior ethmoid air cells. The maxillary sinus will also drain into the middle meatus via the semilunaris hiatus. As you can see here, it's quite small. So in order to see the semilunaris hiatus, you actually have to remove part of the middle meatus in order to see it, but it's right here as well. So the anterior part will lead into the infundibulum, and that will go into the frontal sinus, and then the inferior meatus is going to drain into the nasolacrimal duct. That's why when you cry, you can kind of taste the tears kind of running down the back of your throat or through your nose, because it takes that track. Okay, so the walls, the medial wall is going to be the vomer and the bony ridge of the maxilla, along with the septal cartilage. As you can see here, this is going to be the ethmoid. Here's the vomer. Remember, vomer goes up, ethmoid goes down. This is going to be the extranasal cartilaginous septum, made of hyaline, remember, and then see as it protrudes inwards. Is that the right term? It goes inwards and is the intranasal cartilaginous septum. And this is pretty common, but a lot of people have asymmetrical noses, and that just means that the septum is going to be deviated. It can be in a variety of degrees. For some people, it just means that they have a crooked nose. The moderate stage is when it starts to reduce the area of the second nostril. And then severe is, of course, severe occlusion. And then obstructive is going to be problematic because the person wouldn't be able to get any air through this nostril at all. Why is this important? Because we actually need both nostrils in order to smell well. Because airflow goes in one and then out the other, or through the mouth or whatever. But there needs to be that flow between both nostrils in order to really get the maximum amount of odor molecules to attach to the cribriform plate. The meatuses and the concha were used to turbulate. That doesn't sound right. To add turbulence to the air, to let the air bounce around the nasal cavity in order for the cribriform plate to pick up the maximum amount of odor molecules. So somebody with the obstructive, nasal cavity with the deviated septum isn't going to breathe that well either. And one of the clinical signs is that this person would suffer from sleep apnea. So that means they wouldn't be able to breathe very well at night at all. Okay, so laterally is going to be the nasal concha or the terminates. It's the older term, but they will be in the lateral wall along with the meatuses and the sphenoethmoidal recess, which is going to be all the way back here, right in between the sphenoid and the ethmoid. Okay, so inside the nose there are the coarse hairs, and that's used really to trap larger particles of dust and dirt, and in order for it not to go into the lungs. And the mucus is there to perform two functions. It's there to moisturize the air, humidify the air, and it's also there to trap smaller debris that the hairs weren't able to get. The mucus is filled with some IgA antibodies, So all of that is very vascular in order to secrete the IgAs and to provide a lot of heat in order to heat the air. Because if you've noticed, you smell a lot better when in a warm environment versus a cold environment. So all of that also covers like the cribriform plate to maximize the amount of odor molecules reaching it. So look, we're looking inwards. And here's the crista galli. The cribriform plates would be around beside it. Here are the ethmoidal air cells, the perpendicular plate. Here the middle nasal concha. This is the lateral mass. And the innervation, let's go through it again. The C1, cranial nerve number 1, is the olfactory nerve, and that extends to the olfactory bulbs. So here's the cribriform plate. And the nerves are going to be like free nerves, kind of like pain fibers, because there's no second messenger system in order to be processed by the brain. It is literally you smell things, it attaches to the nasal ciliary nerves, and then the olfactory nerves go straight back into the brain. So sensation is provided by V1, V, and V2 of the cranial nerve, number 5. V1 will pierce the cartilage and supply the surface of the nose, and V2 will supply the turbinates. Okay, so the maxillary branches of the sphenopalatine, anterior and posterior ethmoid arteries will supply the nose. The facial branches, the lateral nasal branches, and the septal branch of the superior labial arteries will also provide the nose with a lot of blood. So they anastomose in 2 places, in Kesselbach's and Woodruff's plexus. So Kesselbach's is right here, where the part of the septal branch of the superior labial artery, along with the anterior, and the sphenopalatine will anastomose right here. And then in the back, in Woodruff's plexus, it's going to be like the posterior and the sphenopalatine anastomosis. And the mucosa in the entire, nasopharyngeal cavity is going to be very thin, is particularly thin in the septum and the vestibule because odor molecules still need to get through in order to attach. And nosebleeds are pretty common because of the thin mucosa, and they can be arterial or venous. Usually it's venous because the veins are not as robust as the arteries, and they can be caused by, just dried out mucosa, which is, fragile, or trauma. And if it's just a dried out mucosa, when you live very far up north and the weather is very cold and very dry, it's usually venous bleeding. If it's a trauma, like you got punched in the face, that's usually arterial blood. So a nosebleed, the technical medical term is going to be epistaxis. Epistaxis. Sorry, can't pronounce things today. And the anterior nosebleeds are the most common, and it bleeds because of Kesselbach's plexus, and this is common in children and adults. Woodruff's plexus is usually the site where posterior bleeding occurs. It's much less common, and it's really associated with high blood pressure and atherosclerosis, and this is usually seen in the elderly. So the lymph of the blood will drain from the nose to the submandibular nodes and the upper deep cervical nodes. So it goes down under the jaw and then in the upper neck. Okay, so the paranasal sinuses are lined with the mucoperiosteum, and their purpose is to reduce the weight of the skull and is used as a voice resonator. So the maxillary sinus, as you can see right here, is the largest one. It's the only one present at birth. They come from the lateral wall of the nasal cavity by the 3rd month. and then just kind of expand, and they get larger as the adult teeth come in. And it communicates via the hiatus semilunaris. Some people have the septa and the maxillary sinuses. That's nothing, clinically significant. It's just an anatomical variant. And if the floor is too thin, teeth can actually, puncture through it, and that might be problematic because that would cause chronic infections and teeth abnormalities. But if managed, it's nothing more than just deviant anatomy. So the frontal sinuses are the last sinuses to develop. They develop as a direct continuation of the embryonic infundibulum and the frontal recess, and it goes upwards. It migrates upwards of the anterior ethmoid air cells during the 16th week of development. And after 2 years, it starts to really show up, and secondary pneumatization starts and ends around age 2, and it ends at age 9. So secondary pneumatization is quite long. This is important clinically because if a patient comes in and says that their child is complaining of a headache and whatnot, and they're under 2 years old, you can't assume that this child has a sinusitis because the frontal sinuses haven't developed yet. So all those chambers communicate and drain down the infundibulum into the middle meatus. The frontal sinus underdevelopment may be caused by early metopic suture closure, but most people it's going to be fairly asymmetrical. You can have one right here and 0 right here, as you can see right here. This person has a really large left frontal sinus, a very small right frontal sinus. Here you can see the ethmoid sinus. Not very well, to be honest, but that's the only way you can see it. The patient has to have their radiograph with their neck, with their head tilted back and their neck up, so you can shoot through the mouth, right? So here's the maxillary sinuses, and all the way back here's the sphenoid sinus. Okay, so the sphenoid sinus grow during the 3rd, 4th months of development as part of the invagination of the nasal mucosa and the posterior part of the cartilaginous nasal capsule. And at first it looks like a pit in the sphenoethmoid recess until about age 3, then pneumatization, and then it extends to the sella turcica by age 7, and that kind of development stops in the mid-teens. Sphenoid sinuses usually have some sort of deviated septum, so that's fairly normal in that. And it can invaginate deeply into the posterior clinoid process and vomer. As you can see here, the progression, first this is not very large at all. Here's the deeper invagination. It's even bigger, and this is this is the largest one. There's hardly any bone at all. The cavity is used to reach the sella turcica, and then in that it's used to reach the hypophysis, and that's where if you have any kind of cancer on the pituitary gland, that's how the surgeons will operate. All of that drains through a single ostium in the sphenoethmoid recess, as if you can recall, it was all the way in the back of the neck. And the lateral wall prominences are going to be the ridges that really stick out into it. And as you can see here, it's going to be the optic, and then the carotid, and then maxillary nerve, and then the Vidian nerve prominence. This is important clinically because you really don't want to be touching any of this during surgery. So you can see here's the carotid prominence, here's the sphenoid septum, here's the sphenoid sinus, sphenoid septa, anterior, this is the pituitary, so you can see here, and the upper clavus. Here's the bulla, middle turbinate, and then this pin going through it is going to be the this is going to be the ostium that drains it, the sphenoethmoid ostium. Here's another picture of the invagination or extension of the cellar, the pre-cellar, so it's like before the sella turcica, post-cellar, and then the conchal would be like here, more anterior. So the ethmoid sinuses are separated by a lot of thin septa, making the labyrinth, and then this is particularly bad because an infection can spread from the sinus right into the orbit and cause a whole lot of problem. It can cause like cellulitis around the eye, and then that can, lead to blindness. Anterior ethmoid will open into the infundibulum and drain down the middle meatus, while the posterior ethmoid will drain into the superior meatus. A little bit backwards, but the bulla ethmoidalis can be a cell or a bone, and the ethmoid bulla is going to be the largest anterior ethmoid air cell. The halar cells are extramural air cells that extend into the inferoorbital floor. So here are the halar cells. And the agarnase air cells are the most anterior, and those are going to be found in the lacrimal bones, while the Onati air cells are going to be posterior to the sphenoid sinus opening. So once again, here's the sphenoid sinus, sella turcica. Remember, it can like invaginate like far deep. There's maxillary sinus. So all of these really are just to reduce the weight of the skull and work as voice resonators. All right, that's it for now. Thank you for your attention and good luck studying.